Thank you for coming all the way. And yeah, so this particular patient, as a 26-year-old male, presented with a hearing loss, has facial palsy, and the tympanic membrane finding on examination was like this kind of a picture. The patient had an intact tympanic membrane with this whitish patch-like finding behind the tympanic membrane. And that's the audiogram with profound hearing loss. And the patient has a complete facial palsy. So you can imagine the clinical situation. Patient has profound loss, complete facial palsy, whitish patch behind the tympanic membrane. Now the question is the diagnosis. This is the plain CT scan, high resolution CT scan without contrast, showing some soft tissue opacity, eroding everything in the petrous bone. See, this is mastoid bone anteriorly, the petrous squamous mastoid bone, and the deeper one is the thicker petrous bone, which is completely eroded. If you compare with the opposite side, see the vestibule, the cochlea, everything eroded. There is no structure, all like a common cavity. Even if you see the intra-aortic meatus, there is no intra-aortic meatus like picture on the opposite side, as the bone is completely eroded by this, we don't know what, this soft tissue opacity. CT scan can just tell you opacity, nothing more. The soft tissue differential diagnosis cannot be given by CT scan. But CT scan gives you lot of information regarding the bony anatomy. So number one, the intra-aortic canal is completely eroded. Now coming to the facial canal. Look at the opposite side, normal facial canal. This is the horizontal facial now, and this is the cochlea. This is the cochlea. Below, this is the horizontal one, this is the vertical petrous carotid, and this is the jugular bulb. Now coming to this side, come from the nasopharynx. This is the horizontal carotid here. This is the horizontal carotid. The bone wall is eroded, completely eroded, and there is a soft tissue opacity medial to it. So what is there medial to the horizontal carotid? Medial to that, the horizontal carotid is the petrous apex. This is the petrous bone where the apex is ending over here. If you look at on the opposite side, this petrous bone is like a conical pyramid, which is right from here ending right over there. This is the apex. Can you see this apex? And which is bounded laterally by horizontal petrous carotid. And look at the apex here, all gone. Entire petrous apex is completely finished. There is no structure like petrous apex. Now coming to the cochlea and vestibule, look at the cochlea on the opposite side and look at the cochlea on this side, completely gone. Look at the vestibule on this side, look at the vestibule on this side, completely gone. So the entire petrous bone with cochlea, vestibule, intra-aortic meatus, everything eroded, finished. The carotid, the medial wall is eroded. The petrous apex is gone. Now what this could be? Then we got the MRI done. Now MRI has the ability by means of various sequences to differentiate the soft tissues, masses. Now look at this. Whatever it was eroded, see this on this side, there's the intra-aortic meatus, cochlea, vestibule, all like a common cavity on this side. This is on T2 weighted MRI, it is hyper intense. Hyper intense on T2. Keep seeing. This is hypo-intense on T1. Let me bring together one by one. See this is hyper-intense on T2 and hypo-intense on T1. Now, number one, had this been a cholesterol granuloma, this would be hyper-intense both on T2 and T1. So that possibility is finished. So this is not cholesterol granuloma. Now I am bringing contrast together. No, first, this is T2 weighted. Now I am bringing contrast. See the contrast now. Hyper intense on T2 and non-enhancing on contrast. Then it rules out the tumor as well. What's my point? So it rules out cholesterol granuloma by hypointensity on T1. It is ruled out as a tumor as it is not enhancing at all. Cholesteatoma doesn't have blood supply for the contrast to reach there and enhance. So, last thing which is required to complete our differential diagnosis is diffusion weighted MRI. On diffusion weighted MRI, it should show restriction on ADC imaging. Though, and this is opposite to ADC imaging, so this is showing restriction. So it cannot be anything else than cholesteatoma. Hello, can you hear me?
Yes, sir. Yes, everything is clear. So, can we label this as a congenital cholesteatoma?
Could be. We cannot, at this stage of 26 here, we are not here to supposed to differentiate between congenital and acquired. Whatever it is in front of us. It could be congenital, you are right. It could be acquired as well. Even acquired cholesteatomas can be destroying the petrous bone, can be so massive. Professor Mario Sana has classified, he has a huge experience of dealing with petrous bone cholesteatomas. I had many a times opportunity to discuss with him in his own theatre many a times. He has a huge series and he classified into 5 categories with some, clinical significance in each category. He classified into apical, into supralabyrinthine, infralabyrinthine, massive, infralabyrinthine, apical, according to the approach required to deal with it. According to the pathway of spread, he has classified, and this kind of a cholesteatoma is a massive one. This has completely destroyed the petrous bone. So this is a massive one. Now, in lateral skull base surgery, to decide the approach, there are lots of factors to be taken into consideration. Important factors to be taken into consideration to decide the surgical approach. Number 1, hearing. If hearing is gone, then hearing sacrificing approaches are most suitable because they are direct approaches. If hearing is gone, then transtemporal approaches are the most direct ones. If hearing is preserved, then you have to look for the alternative approach. Similarly, the second structure which need to be taken into consideration for decision making is facial nerve. If facial nerve is preserved, then accordingly you have to choose the approach which can preserve the facial nerve and you can go deep to the tumor. Now there are various rerouting approaches have been described. You can reroute the facial nerve and go deep to the facial nerve and remove the tumor without paralyzing the facial nerve. So if the facial nerve is intact, then you have to choose the approach accordingly. In this case, there is a profound, there is a grade 6 facial palsy. So now, this is a direct case for none other than transcochlear approach. The approach which gives widest exposure in lateral skull base surgery. We have to go by modified transcochlear approach which is described by Professor Mario Sana. Transcochlear approach was earlier described by Hugo Fish which was modified into various, types according to Professor Mario Sana, depending upon the extent of the lesion. This is a classical case for modified transcochlear approach type 1. And in case we have to mobilize the carotid artery, because the horizontal petrous carotid is involved by the lesion, the medial wall is completely destroyed by the horizontal, by this cholesteatoma. Horizontal petrous carotid, medial wall is destroyed. So we may have to take into control. So along with the modified transcochlear 1, we may have to go anteriorly by the fish type 2B approach. So it may require a modified transcochlear B type approach. We'll start with the A, and in case required, we'll convert to type B. So our goal is complete removal of cholesteatoma. Cholesteatoma means everywhere, whether it is small, big, massive, the goal is complete removal. Number 1. Irrespective of anything, the goal is complete removal. Now, in this situation, where the cholesteatoma, which has been so massive to have eroded all around, eroded the sigmoid sinus wall, eroded the facial, eroded the internal auditory meatus, which has a high chance of giving CSF leak. In this particular case, there is almost always in such situation there is a CSF leak. The moment we approach the internal auditory canal area, remove the cholesteatoma, we are likely to have a CSF leak, and we will seal it accordingly. So in the situation where the dura is eroded, carotid is eroded, all vital structures are eroded, we are not supposed to keep the cavity open, like open cavity to keep draining and discharging. We cannot afford with such vital structures exposed. So number 1 goal is to remove cholesteatoma. Number 1, to make it safe by obliterating the cavity to prevent future infection. And for that, for the patient to be enabled to be obliterated, cul-de-sac closure, the cholesteatoma complete removal is must. Otherwise, it's a disaster. If you obliterate the cavity with the cholesteatoma behind, is a disaster. So first goal is, ideally, is transcochlear approach, complete removal of cholesteatoma. Second, complete removal and cul-de-sac closure, obliteration of the cavity and cul-de-sac closure. Third is, during surgery, see the tumor is going far anteriorly. I will show you how it is going underneath the horizontal petrous carotid. We need the help of endoscope, and here we are champions of endoscopic surgery with team of Mubarak Khan. So we'll take the help of angled endoscope and inspect the entire cavity at the end of the surgery, particularly deep to the carotid, horizontal carotid, to see that cholesteatoma is completely removed. Now, question is difficulties. Obviously, the lesion is so big and all around the vital structures are exposed. CSF leak is likely. Now, the question is complete removal challenges. Number 1, if the cholesteatoma is adhered to the carotid canal, you have to be extremely diligent to remove it thoroughly. You cannot afford to be aggressive to damage the carotid artery wall. So number 1 challenge, particularly in the depth, will show you where you cannot see even with your straight angle microscope. We may have to take the help of endoscope, angled scope to go right deep to the horizontal carotid to ensure the complete cholesteatoma is removed. With the bone eroded, the cholesteatoma adhered to the artery, and that too in the horizontal carotid where the periosteum is absent, is the biggest challenge, removal of cholesteatoma. So you have to be extremely diligent to remove the cholesteatoma from there. Number 2, the removal of the cholesteatoma from the dura. Again, it's a big challenge. What we do in such situation when we are on a very, very critical area and we are not able to ensure complete removal, microscopic complete removal, we can do a bipolarization to devitalize the cholesteatoma. Cholesteatoma is just skin which proliferates. So on dura many a times what we do in that particular region, if the aggressiveness of the resection is likely to give CSF leak, we can be little less aggressive and bipolarize that area very, very effectively to devitalize the skin, that cholesteatoma, to prevent further proliferation. Similarly, removal from the sigmoid sinus again is a big challenge. If there is a cholesteatoma on the jugular bulb, is the biggest challenge, because jugular bulb again lacks periosteum, and the rupture is likely if you are too aggressive to remove the cholesteatoma from the thin wall. And in this situation, even we have done couple of times, went in the neck, obliterating like in glomus jugular surgery, what we do, closure of the sigmoid sinus and closure of the internal jugular in the neck, open the wall involving the jugular bulb, open the jugular bulb wall involving the cholesteatoma, and remove it completely and obliterate the inferior petrosal sinuses inside. So you have to be that aggressive to remove the cholesteatoma if you are obliterating that cavity. Now, in such situation where everything is exposed, dura is exposed, internal aortic canal is leaking, carotid is exposed, sinus is exposed, how can you afford to leave an open discharging cavity? It is likely to invite infection. So you have to do every possible effort to remove the cholesteatoma completely. That's the only chance to give patient a cure and a safe life. Otherwise, if you obliterate with the cholesteatoma inside, is a disaster. And if you don't obliterate and leave a discharging cavity with all vital structures exposed, is again a disaster. So the challenges are many, and let's see how to deal with such situations and what we have been doing so far over the period of years. So any questions, any suggestion? Professor Marchioni, anything you would do extra? Anything change in your approach?
Yes, in my experience, for me, in case my plan is, of course, a transcochlear view and infratemporal fossa type B, in order to following the horizontal portions of the carotid artery, exposing the middle meningeal artery and U3, because you know that here along the horizontal portions of the carotid artery,
Absolutely.
It's a form of sedation.
Absolutely. Thank you. Two things. What you mentioned. First, about the carotid, you know, I would say the study of the carotid flow. We do generally recommend the carotid artery study or cross flow studies when we are dealing with the tumors. I know anything involving carotid artery when you are dealing with it, one has to stay on the safer side to get the cross flow studies done. So, in any given unfortunate circumstance, if you happen to lacerate, you can obliterate the vessel. But here in this scenario, this is not a tumor, so we generally stay, choose a different approach and avoid too much dealing with the carotid artery. We'll try our best to peel it off, like you said, with a wet cotton ball, or and we'll do lot many maneuvers to remove that, but not with any sharp instrument to lacerate the artery. So, I do not deny your approach to get the cross flow studies done. It is always better to have that. Agreed. Number two, regarding the facial now. In this scenario, we are unlikely to find the proximal stump of the facial now. At this is a, you see, this is a complete cavity. That's a complete cavity. There is no bony landmark anywhere. Even the trace of the intra-aortic canal is not visible. So it has completely destroyed the neurovascular structures in the intra-aortic canal. And the moment we remove, we are almost always likely to get CSF leak in this situation and unlikely to get any nerve stump. So in such situation, our approach for facial rehabilitation, the number one approach in the scenario is the fasciomesenteric anastomosis. That we do sometimes same stage, sometime according to the patient and situation, second stage. But our rehabilitation, for rehabilitation, number one approach is fasciomesenteric anastomosis. Mesenteric is the one which has the same area of representation in the brain with the facial now, involved in facial expression, very close proximity, and hardly any physiotherapy is required once you do fasciomesenteric. It has been our number one, donor now for the facial rehabilitation for last decade. So our approach in this case is, I don't think we'll be able to get any proximal stent for any nerve grafting. What I believe.
Yes, I agree totally. Is it possible to do a cable graft reconstruction in this case? But you have to perform a different kind of facial nerve rehabilitation, like, of course, masseterin or hypoglossal facial nerve anastomosis, and you can do it a second time. Of course, it's not a big issue, but of course, it's not possible to do a cable graft reconstruction. Also because you have to do the reconstruction from the stab in the cerebellopontinello to the peripheral portion of the main trunk in the parotid gland or mastoid segment of the facial nerve, and the results are honestly not good. So, no sense to try to do a reconstruction in this case. But instead, a facial nerve rehabilitation with hypoglossal facial nerve anastomosis or masseteric anastomosis could be really nice in the future, of course.
Yes. Anybody having any question or suggestion before we move on to the surgical part?
I request Dr. Devi Prasad, our president, to felicitate with a momentum. Please, sir, I would like to talk two words for my boss, because this is the man who converted me from microscope to endoscope. So the first workshop which we did endoscopic and microscopic way back 15 years. Sir versus Pusalkar sir. And then he started converting me to, and I become an endoscopic here surgeon.
बाहर के स्टिच हटाने अपने को स्टिच सूचर से वाई टू वेस्ट
Good afternoon to all of you. I thank the SEOCON organizers, Mubarak and team, on asking me to give a talk in the legend session in endoscopic optic orbit and optical surgeries. Now this endoscopic sinus surgery is basic, and is just an extension of the endoscopic sinus surgery. Is it?
sinus surgery?
So thorough knowledge of the sinuses and anatomy is important. See, advantages of the endoscopic surgery you can see in the picture that depicts. The endoscopy can assess the medial, superior medial and inframedial aspects of the orbit of the sinuses. So the other advantage is visualization, magnification aids us in removing pathologies from the orbit and optic nerve. Angle endoscopes can help us to know. So there's no eyeball distraction and also brain distraction. Previously the people damage. So that is not necessary in the endoscopic approach.
This is the best.
Because it's the same mode. So I'm going to enlighten you with the videos of the orbit and optic nerve. Pathologies from the sinuses are coming to the orbit. So it is first seen by the ophthalmologist or a neurosurgeon, and they refer to us, and we deal with that endoscopically. So thyroid eye disorders can optic nerve pathologies, which are blindness and optic nerve cranial lesions, can be done by the skull-based surgeons. So this is a first case, a patient who came in COVID time, complaining of protrusion of the eyeball and drooping of the eyelid. So CT scan shows erosion of the roof of the, the floor of the orbit, and some.
Yes.
You can see extensive polyps in this right basal cavity, which was debrided, and then the antrostomy is done in the first and eyebrows because of the sphenoid and sinus open, and again infected material removed. The frontal recess was widened, and using a burr, the axilla of the frontal sinus was drilled, and also the superlateral of the lateral wall of the orbit was drilled and thinned out and removed. Next was the lateral aspect, lateral recess of the frontal sinus, and on pressure from the orbit, you can see the first coming from the eyeball into the sinuses and completely drained. And so, Robert Lepek's decompression time for thyroid eye disease. So this patient had mild proptosis, and the ophthalmoplastic surgeon referred this patient to me, saying that color vision is affected because of compression of the optic nerve.
हाँ जी
So this is the procedure where you get the first signs of this is color vision is lost. So it's an early sign and we should take immediate action. So this video shows the colpoplasty being done. The
ट्रैक्टर छोटा है
Ectorectomy, anterior posterior, sphenoidal sinus open. You can see the polypoid tissue removed. And
बड़ा चाहिए
can see the lamina propria on the lateral side.
चलो छोड़ो लगाते रहेंगे सक्शन सक्शन
Open and widen.
आ जाओ ड्रिल
Expose the orbital apex. That is the orbital apex and that is the optic nerve. So the
हाँ
optic canal is drilled. Now bone is drilled to thin out out
बाइपोलर दिखाना एक बार
and then removed. The optic
जब मैं बाइपोलर करूँ तो पानी डालना किधर है बाइपोलर का पेडल और ड्रिल का
So incisions made in the sharp knife for the periorbital. So that is the orbital bone and optic apex being removed, and you can see the optic nerve is posteriorly clear vision. So the incision being made and orbital part is collapsed into the
ठीक है
nasal cavity for decompression. So next I'll be incising the optic nerve sheath to decompress the optic nerve. So similar procedure was done on this other side of
एक और है
since the bilateral disease. So from the optic apex, the incision is made with sharp knife or the optic nerve sheath. Here the advantage is the endoscopic gives access to the medial one, medial 180 degrees of the optic nerve. So this is a
कैनाल को आगे कर दिया मैंने
this patient came to
कैनाल
me with injury in the left
हाँ
forehead.
अब कुछ भी नहीं आएगा
Vision
हाँ
on the
करेंगे ना
right side.
अब कुछ बीच में नहीं आएगा
CT scan showed a fractured fragment
ठीक है ना
impinging on the.
बिकॉज वी हैव टू गो वेरी डीप अब मोनोपोलर कॉटरी
This is a small video showing the same procedure like transcarotomy, laparotomy.
देखो ये जो कैनाल है ना
This is optic canal showing the fragmented bone compressed
उल्टा लगा है?
optic nerve. The
लगाना मैडम
proximal distal part of the optic canal was
हाँ, लगाओ
drilled to thin it out.
करो करो हाँ खोलो
Fractured segment
हाँ
was
हाँ
removed by elevators.
चलो ठीक है
And a hematoma was formed which was drained. So the proximal distal part of the optic nerve canal was removed by punches. So the optic nerve was decompressed in this patient, recovered well, to regain his vision. So this patient again we got in report time by now optical glaucoma of this, having an optical frozen eye. He had 2 surgeries earlier, also thing, but he didn't do. So the image is showing that is the disease involving the sphenoid sinus, the cavernous sinus, the optic nerve is involved, the invertebral fossa, or superior optical fissure. So the patient had blindness. So we opted for endoscopic cause. There are lots of modified endoscopic procedure to remove the anterior wall of the maxillary sinus. That is the lacrimal
Sorry.
which is exposed to open
गौरी
since we had to cut
गई
the
टूथ
lacrimal duct. So the fungal material is removed from the invertebral fossa, then pterygopalatine fossa. The sphenoidal sinus is identified and widened.
हाँ
The middle terminate is being
ड्रिल
So the lateral sphenoid sinus is turned out, expose the cavernous sinus. So that is the superior optical fissure and optic nerve. The divider is being removed to remove the disease from the optic nerve and orbit.
ये मैंने इसलिए कॉटराइज किया है क्यों जलाया है
So for the
नो स्किन शुड बी लेफ्ट लैटरली
fissure to
वो कल्डी सेक में अंदर रह जाएगी, वरना कल्डी सेक में अंदर स्किन रहेगी ना तो डिजास्टर। तो उसको हाँ, तो ये इसको बहुत एग्रेसिवली है ना, मैंने इसलिए गौरी वाई आई कॉटराइज दिस लैटरल स्किन, जो लैटरल स्किन मार्जिन है ना जहाँ कैनाल काटी है, देयर शुड नॉट बी एनी एपिथेलियम लेफ्ट बिहाइंड, सो आई थॉरोली कॉटराइज दैट एरिया। देखो जहाँ कोलेस्टेटोमा हटा नहीं सकते ना, डिवाइटलाइज दैट। बंद, हाँ 2 सेक्शन रखो, सेक्शन ड्रिल ड्रिल ड्रिल, पानी फुल 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 और तेज, मोटी नीडल लगा लो, 18 नंबर सेक्शन टिप लगा लो। डालो 50 सीसी सिरिंज है आपके पास, वो ले, ये तो बार बार भरनी पड़ेगी आपको। मेरा तो उठाना ही मत, एक बार कान पे लगा दो यार, देखो आईसीयू से कर रहा होगा, चलो रहने दो। अपने पास कॉनिकल भर रहती है, कॉनिकल भर, कोई बात, पानी जोर से, पानी नहीं डालोगे क्लॉग होगा, कोपियस इरिगेशन। Here digastric ridge, Gauri, this horizontal is the digastric ridge. Yes, yes. यहाँ फेशियल आने वाली है अपनी, यहाँ, और इधर ऑलरेडी गई हुई है तो टेंशन ही नहीं है। अरे फेशियल देखना, प्रॉक्सिमल स्टम्प मिलने वाला ही नहीं है, और सब कोलेस्टेटोमा में इंट्राऑटिक कैनाल ही खत्म हो गई, जहाँ से नर्व आती है ना, देयर इज नो एविडेंस ऑफ इंट्राऑटिक कैनाल। अभी देखना सीएसएफ आएगा मस्त। क्या? हाँ तो ना कुछ नहीं, नहीं मिलेगी। इंट्राऑटिक कैनाल ही खत्म हो गई। ये अभी क्या है, क्रूड वर्क मैं कर देता हूँ जब तक ये लेक्चर चल रहा है. ड्रिलिंग देख के क्या करेंगे, रोज खुद ही करते होंगे सब. देखो पूरा मार्सुपलाइज कर दिया मैंने. ये जो एजेज है ना, नो बोन इज देयर. My sinus is here and I am beyond there. पानी डालो, धोना है इसको, धोना है. इधर इधर. एक साइज मोटा सक्शन टिप ले लो आप. ये बंद. ये तो बहुत पतला है बॉस. ये खोलो. हाँ हाँ, ये थोड़ी चल रहा है. मोटा चाहिए. Hello. Okay. So, as you all know, what I described during radiology, that this is a case of uterus bone cholesteatoma with a facial palsy, funny, wash, and profound hearing loss. Cholesteatoma involving all deeper vital structures, and our approach is a transcochlear one, for which need a wide exposure. और देना एक, ये बोन डस्ट है ना, ये बार बार क्लॉक करती है. So, until the lecture was going on, I just did a lateral crude work meantime to show you the landmarks. That's the sigmoid sinus going, and this is the lower down. I remove the mastoid tip, and what you see there is the digastric ridge, diamond. See, these are emissary veins behind, if you see carefully. They maintain the intracranial and extracranial pressure by releasing the pressure from the sigmoid sinus. So, once they are bleeding, you can use simply the diamond burr, dry diamond, to clog with the bone dust. In lateral skull base surgery, for bleeding management, for bone, bleeding from the bone, you have tools like dry diamond or bone wax. For bleeding from the soft tissues, we have tools like cautery or Surgicel. So we have to be having all these things in our armamentarium. So to orient, we have already cut the extraordinary canal from here. That's the medial part of the canal. That's the lateral end of the canal, for which we'll do cul-de-sac closure later. Just to orient you. Now, cutting bar. Now I'm quickly excentrating all these air cells. We have to go deep to the petrous bone. Our area of interest is the petrous bone. All these lateral squamous, mastoid, tympanic, all these bones have to go. That's the sigmoid sinus. That's the tegmen plate. Above this is the tegmen plate. In transcochlear approach, your exposure is posteriorly from the sigmoid sinus to anteriorly to the level of the carotid artery, petrous carotid. Superiorly from the tegmen to inferiorly to the level of the jugular bulb. All structures coming in the way have to go. So this is the preferred approach, giving widest exposure when you have already, the disease or the lesion has already sacrificed the hearing as well as facial nerve. And this is the right indication in this scenario. That is the glimpse of the lateral part of the facial nerve, petrous bone, the canals, the lateral ends of the canal appearing medially, they are all destroyed. पानी कम डाल रहे हो? That's the fallopian canal. That's the part of the tympanic bone which I have to remove extensively. That's the anterior canal wall. Bipolar. That's the parotid tissue. all the cellularity anterior to the sigmoid sinus has to go. That a pre-sigmoid dural plate. Pani, full pani. Our lower limit we have to define that the vertical facial now we will sacrifice it. Later on we'll do some nerve anastomosis. All soft tissues around. This is remnant ossicles. See the cholesteatoma sac on the, here is the cholesteatoma sac. Drill. So I did all this lateral crude work first so that we can focus on the more important areas below. Funny, घर के ऊपर हाँ. This is the zygomatic root. In this case where the horizontal carotid is affected from below, we may have to go far anteriorly and then this zygomatic root has to go completely. See, this is the cholesteatoma sac, Gauri. Gauri, are you here? Yeah. That's the facial nerve. And see what is there below the facial nerve. These are the semicircular canals. See, when I am drilling the semicircular canal, what is there underneath? All semicircular canals have to go. See, this is cholesteatoma. See, deep to the canal, this is all cholesteatoma. So first we have to achieve the exposure. Carotid to sigmoid, this is zygomatic root. पानी जोर से इधर जहाँ ड्रिल आगे हाँ यस हाँ वो बताऊँगा semicircular canal, facial nerve, all gone. entire inner ear being eroded, being removed, and see the cholesteatoma in the depth. Still my inferior exposure is not complete. Will go till jugular bulb. बाइपोलर को कम किया क्या किसी ने? This is all cholesteatoma. See, this is all cholesteatoma. All cholesteatoma. ये रखो. Give me drill. यूँ पकड़ना थोड़ा सा. वो एनेस्थीसिया वाले टिल्ट कर सकते हैं कि टेबल? ये ब्लॉक हो गया. Yes, little bit, 5-10 degree. Yes. I am going down towards my lower limit, that is jugular bulb. See the cholesteatoma. इसको लग गया बाइपोलर. Can you increase the bipolar? नहीं भर नहीं, बाइपोलर चला रहा हूँ. Drill. This is all cholesteatoma. This is all tympanic bone. Medial to tympanic bone is the jugular bulb. You can see the glimpse of the jugular bulb now. This is jugular bulb. दिख रहा है गौरी? ये रहा सेक, ये रहा ना, सेक ही सेक है। अरे कॉक्लियर, अब तो कैरोटिड देखेंगे। डायमंड है ना। दिस इज ऑल कोलेस्ट्रेटोमा। ह्यूज कोलेस्ट्रेटोमा, ह्यूज कोलेस्ट्रेटोमा। सो व्हाट? Now using the diamond burr to skeletonize our landmarks. पानी पानी copious. So upper limit is the Tagman in transcochlear approach, and lower limit is the jugular bulb. Posterior limit is the sigmoid sinus, and anterior limit will show you the carotid artery. Band. See the matrix. See the matrix. See how the matrix coming out. Yeah, this is cochlear aqueduct. वो तो आना ही है। हाँ हाँ। That's the dura. Dura. Oh, bipolar. अब देख रहे हैं, सो गए दिखते। डायमंड मेरा जब केस खत्म हो जाएगा जब ले लूँगा। 100%. थोड़ा सा रुक जाओ बस. See, this is my inferior limit, posterior limit. This is posterior fossa plate. This is all posterior fossa plate from where I elevated the matrix. Cutting. Now superiorly, this is all matrix. See the remnant of Peter's bone. See the matrix, diamond. This is superiorly. This is superior petrosal sinus here. Diamond. Periosteum. This is from dura. Forceps. Drill diamond. All dura. अभी इसमें टाइम लगेगा सॉरी. तो तुम फैट भी निकाल दो ना. निकाल दोगे? बहुत बड़ा चाहिए. all around. You have to stay careful at the limits. नहीं 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 लेट नाइट लेट नाइट intra-meter. So that's the region of the intra-auditory meter. Here. Periosteum. That's the region of the intra-auditory meatus. Periosteum. Now I'm elevating from the posterior fossa dura. Above was the middle fossa dura. Here is the posterior fossa dura. And this is where I am working, is deep to carotid artery. Carotid artery is here. Here is my carotid artery hanging. Yes, that's what I said on the scan. We have to go deep to the carotid and we'll take help of the endoscope. See the carotid hanging in the field. This is carotid. Yeah, that's what I said. Never try to remove it early. Take the help of the bulk. See the under surface is clear? Yes. That's the carotid wall. That's the horizontal petrous carotid. इधर करो यहाँ यूँ रखो यूँ हाँ यूँ दबा के see this, that's the vertical petrous carotid and this is the genuine becoming horizontal. Everybody got it? Enjoy the view. And this is the sac deep to it. Can you see? And being removed in toto. See this? Matrix. Forceps. Microforceps. So carotid is hanging and under microscope I could remove the entire matrix intact. Bipolar. ये क्यों करना? हाँ कर दो. हाँ बोल दो. हाँ कर दो. Who will harvest? Big one. diamond. हॉल में लोग है क्या कोई? हॉल में है कोई? So now everywhere in the periphery you have to be 100 times sure that no matrix is left behind, because that's why try to remove it intact. Now I am drilling that's the last part of the Peter's apex. I am drilling deep to carotid. यूँ रखो यार, यूँ मेरा व्यू दिखना चाहिए। यहाँ रखना, ये हिलाना नहीं। हाँ, पेरियोस्टियम देना। पेरियोस्टियम यूँ। हाँ हाँ, सी द इंटैक्ट सैक रिमूव्ड। क्या बोल रही हो? That's the carotid wall. You have to stay very careful while dealing with the horizontal petrous carotid. It doesn't contain periosteum lining. नहीं, bipolar. This is the area of the dura. Though I have removed intact under vision, देना थोड़ा bipolar कम करना। चलो पानी खूब खूब सारा पानी, परफोरेशन हो जाएगा अभी। हाँ चलो चलो, पानी खूब, पानी खूब। See what I am doing? Devitalizing if any remnant, though I am quite sure I am that I have removed under vision, but still I don't want to take a chance. And this entire critical area being devitalized, the lining. Though everywhere we did a blend dissection, नहीं अलग अलग, थोड़ा बड़ा भी चाहिए होगा। बाइपोलर, ओ सॉरी, ड्रिल डायमंड। All these margins have to be thoroughly drilled, so not to leave any hidden skin underneath them. See these bony margins, they harbor some time. पानी पानी जम के पानी. Bipolar. So from this side it is done. Don't want to take chance with this thin bone. That's it. Now coming behind. See the transcochlear approach. Jugular bulb, sigmoid sinus, carotid artery and the tegmen. Below this is all posterior fossa dura. See this pulsatile posterior fossa dura. Bipolar. That's the stump and that's the intraocaustic meatus region. Finally, मेरी तरफ periosteum. Periosteum. Intact. Intact. That's the final part. Bipolar. That's the intra-auditory meatus. Everybody, look at the intra-auditory meatus, the nerves coming out of it. From where the CSF is coming. See this? And this is, I told you will not get any stump for reconstruction. That will seal for the CSF leak. This is the site of leak. I told you it was inevitable. All mucosa which I am devitalizing. Pani, pani, pani. Endoscope. I want a 70 degree to see underneath the carotid. So that's all about the cholesteatoma removal. And see the excess. To me, this is the largest access in lateral skull base surgery to the skull base. This gives the most direct approach, periosteum. You can deal with all vital structures with your both hands free. Drill देना. Our entire lateral skull base work is always dedicated to one and only Professor Mario Sana, and then after our own Morwani sir. They have devoted their life to teach us this science of lateral skull base. Professor Mario Sana is phenomenal and revolutionized the concept. And he's as fit as ever, touch wood, and still continuing his work at the same pace at the age of 80. क्या हो गया कॉटरी को? चल गए. Endoscope. $70. कहाँ देखूँ मैं? नहीं वो लॉक कैसे हो गया? लॉक क्यों नहीं खुल रहा? Why this is unnecessarily locked? So now हटो आगे से. What I am trying to show is the carotid artery from below. Something, Savlon or something. Wet goes दे दो यार. This is with a 70 degree. You can see this is vertical petrous beating carotid. That's the genu and that is the horizontal petrous. And what we have removed, the cholesteatoma from everywhere. So this is very important to ensure by endoscope. Now, to the intra-aortic meatus. Now, that is the area of the intra-aortic meatus. That is the area. See from where the CSF is coming out. This one. See the rent. That is the intra-aortic meatus, and we will seal with a muscle plug. Give me a knife to harvest the muscle. We can even suture the muscle if. So that's all about. Now we'll obliterate the entire cavity with the fat and do a cul-de-sac closure. Knife, please. ये अटक गया ना? Locked. The microscope is locked. I don't know why. if you want to assess how deep you are, let me show you. See how deep we are. That's the level of the carotid. ये चेंज करो ना एंडोस्कोप का कैमरा. फैट मेरे को इधर दे दो थोड़ा, इंट्राऑर्टिव मीटर्स में डाल दो. एक मिनट आया गौरी, इससे कुछ नहीं होगा यार. इससे क्या होगा, तुम कैविटी देखो. सी दैट्स द कैरोटिड. ये फोकस नहीं है, मैं एंडोस्कोप फोकस करो ना कैमरा, जरा कैमरा फोकस करना प्लीज, वो कैमरा. See, if I place my in the depth this periosteum elevator, see this edge at this point. Let me show you how deep we are. So deep we are from the cortex, right from here is more than 6 centimeters deep we have gone. हाँ, फैट है ना, इससे कुछ नहीं होगा यार. फैट कम है क्या? मैं निकालता हूँ. सीजर देना, सीजर्स.
फेशिया भी निकालना है? फेशियल आटा भी लगेगा?
नहीं नहीं. थोड़ा सर्जिकल देना. The fat is soaked in rifampicin. Surgical. काट दो इतना सा. See, it is plugged like this, half in, half out. That's it, self-folding. Yeah, this is self-folding. So this will not allow the CSF to come out now. Give me more fat. More fat. दे दो अंदर, डाल दो, फेंक दो अंदर. डालो अंदर. डालो जो भी है. नहीं, इसे 2 टुकड़े करो. 2 टुकड़े बराबर के. So this is plugged here in the hole. क्या करेंगे, दे दो. हो तो दे दो. अभी ये बना दिया क्या? बना रहा है. लो आधा फेंक दो. आधा फेंक दो अंदर. यस. So now this fat deep to carotid, deep to here. See, the leak is plugged. और दो आधा. एज टू एज, बल्कि थोड़ा इससे निकलना चाहिए. सो इट रिमेन्स प्रेस्ड.
पर वो पेरियोस्टियम कवर करेगा क्या इतना?
नहीं, पेरियोस्टियम आधा ही कवर होगा.
हाँ, वही तो.
बस ठीक. तुम इधर से एक इस एंड पे, एक स्टैंड पे 2 स्टेट और कल्टी कर दो. बस इसको बंद करना है, कुछ नहीं.
थैंक यू सर. ग्लू बनाया था वो डालना है. ये फैट के ऊपर डाल. हाँ,
ब्रीफ केस में ले जाता हूँ.
नहीं बनाया, फोड़ा है 12,000 डाल दे.
अब कहाँ डालोगे? इसे डाल दो इसके चारों तरफ.
हाँ, इसके ऊपर डाल दो ना.
फेट के एज पे डाल दो चारों तरफ.
हाँ, जितना रहेगा ना.